Everybody, a very warm welcome. We wait 1 more minute for any last-minute participants who want to join, and then we will start the session. A very warm welcome from Basel to this session 3.4 entitled Introducing Pediatric Praziquantel for Schistosomiasis Control, Platforms and Approaches. My name is Peter Steinmann. I'm an epidemiologist at the Swiss Tropical and Public Health Institute in Basel, and I am co-leading the access sub-team of the Pediatric Praziquantel Consortium together with my colleague Jenny Burrell, who is the rapporteur of this session here. This session is introducing pediatric praziquantel, which will pave the way to systematic anti-schistosomial treatment of preschool-aged children. And the goal is to discuss operational research needs and other preparations necessary to identify locally adapted integrated delivery platforms and distribution approaches. We have defined 3 outcomes we would like to achieve, and these are: first, to learn from relevant previous experiences with pediatric drug treatment and infectious diseases of poverty; second, to discuss needs and approaches to prepare for the introduction of pediatric praziquantel; and third, to identify operational research needs and evidence gaps to facilitate quick adoption and rapid rollout of this new drug. The agenda suggests 4 short presentations. They will be now at the beginning, then a very short moment for clarifying questions, followed by breakout rooms. We have 2 breakout rooms, half an hour each, and then a restitution where we bring together the key insights from the discussions in the breakout rooms. And without further ado, I would like to introduce the first speaker. Beatrice Greco is the head of research and development and access for the Global Health Institute of Merck, and her current focus is on pediatric praziquantel. Beatrice, over to you for the first presentation.
Thank you very much, Peter. Let me share my screen. Okay, so thank you very much, Peter. Ladies and gentlemen, good afternoon. As Peter mentioned, I'm Beatrice Greco. I'm part of the Merck Global Health Institute, and today I'm going to be speaking on behalf of the Pediatric Praziquantel Consortium. In the next couple of minutes, I'm going to give you an update on the development and access status of the pediatric praziquantel formulation. Of course, in front of such an expert audience, I'm not going to get into the details of what schistosomiasis is. It's sufficient to say that this is and remains a major public health issue in endemic countries. We're talking about 240 million people requiring treatment, children and adults that are going to be spending up to a third to half of their lives with this infection, and therefore leading to very severe health impacts. The current standard of care is praziquantel. Through the donation of Merck to WHO, school-aged children are being treated. And in 2019, for example, we do see that about 100 million of school-aged children, as well as some adults, have been treated. However, to reach the NTD roadmap goal of elimination of schistosomiasis by 2030, it requires that all population at risk are being treated. And this has been reinforced by the WHO schistosomiasis guideline recently issued. And this includes also preschool-aged children. This is actually a neglected population in this schistosomiasis environment. And now we recognize that there's around 54 million of preschool-age children that are at risk of schistosomiasis and who are remaining untreated in public health programs, due to the fact that there's no suitable child-friendly formulation to treat them. This gap was the foundation of the formation of the Pediatric Praziquantel Consortium in 2012. Actually, we're celebrating our 10th anniversary this year. The goal of the Pediatric Praziquantel Consortium has been to develop this pediatric formulation of praziquantel, register it, as well as to deploy an innovative mechanism, stepping away from donation, but allowing for equitable, sustainable access of this new product to the most vulnerable population. So what have we achieved so far and where are we at? We do have a formulation. This is based on the L-enantiomer of praziquantel, the biological active enantiomer. It's a small size, allowing for precise dosing. It's orally dispersible and has reduced bitterness. Very stable in hot and humid conditions or tropical regions. And the manufacturing process has been simplified in such a way that it allows for low cost of goods as well as transferability for manufacturers. Not only do we have a formulation, but we have conducted a full clinical development program with endemic country partners. And this is not a very usual situation, so it's good to highlight it. It went from test studies to phase 1, phase 2, and phase 3 confirmatory study that has been completed in 2021. The results are showing efficacy and safety data with favorable profile. Indeed, we met the primary endpoint of cure rate for Manson-I and hematobiome, high egg reduction rate, no new risk or safety concerns that were identified, and the 50 milligram kilo for SM Manson-I and 60 milligram kilo for hematobiome demonstrated favorable safety, tolerability, and improved palatability among the preschool age children. Where are we at now? We are preparing the next steps, which is preparing the submission dossier to EMA and for all application. We intend on doing this by the end of this year. We expect to have and hope to have a positive scientific opinion by EMA by the end of 2023. Meanwhile, we are going to be working with WHO to enlist the new formulation into the WHO Essential Medicines list, but also to acquire pre-qualification. We are also exploring to apply for WHO collaborative procedure to accelerate registration in local endemic environments. But this is not all. Actually, to translate all this R&D into impact, it requires also to put in place a sustainable access path as defined by the consortium, being away from a donation, but allowing equitable access. And this is based on various pillars that we are currently exploring in parallel. The first one being working with the countries at the level of understanding the policies in place and what needs to be updated to ensure early adoptions of this new formulation into their country. Second, it's working also with organizations such as WHO and countries to understand how we are going to generate demand and the forecast. We need to be informed about how much do we need to produce. As we said, we are stepping away from donation model to move toward a non-for-profit access model, which is an innovation in the NTD space. So this is a place where we have a gap, and we are looking at innovative procurement and financing models to be put in. From a manufacturing perspective, we have already moved forward toward a technology transfer in Kenya to ensure large-scale manufacturing. From a delivery and supply perspective, we are looking also at existing platforms. How can we leverage from them to ensure cost effectiveness for implementation? And finally, the last, but certainly not the least, is to address together with country partners the question of identifying the implementation platforms by which the preschoolers are going to be treated. And this is done through the ADOPT program that was launched in 2020. So with this, I'd like to simply conclude by thanking and recognizing also the very important contribution of all the partners of the consortium for the last 10 years, and very likely for the next 10 future ones. And the last, and certainly not again the least, it's our funding partners and contributors, the Gates Foundation, GHIT, as well as BC. With this, thank you very much for your attention.
Thank you very much, Beatrice. This was a very good overview over the history and where we are, where we want to go with the Pediatric Praziquantel Consortium's work. This is now followed by a second presentation from Prudence Benamario, is the program manager in the Vector-Borne and Neglected Tropical Diseases Department in the Uganda Ministry of Health, and she will give her presentation, has been pre-recorded, but she is available here for questions later.
Good morning to you all, and good afternoon to you all. Those ones who are in the time zones of good afternoon, and those ones who are in the time zones of good morning. I'll begin with an introduction. My name is Prudence Benamario. I'm the program manager, Bilharzia and Womb Control Program, Ministry of Health in Uganda. I want to take you through the topic of strengthening schistosomiasis MDA through the introduction of pediatric praziquantel formulation. Uganda is among the countries that are endemic with schistosomiasis, and the prevalence is we have the one that ranges from high endemic to low endemic. We have schistosomiasis in more than 95 districts out of 146 districts. 38 districts are categorized as high endemic, 15 districts are categorized as moderate, and 42 districts are categorized as low endemic districts. Currently, the main strategy we are using to control schistosomiasis is MDA in school-age children, and sometimes or rarely at-risk adults. MDA has been enrolled in all the endemic districts. MDA with praziquantel has shown to be effective in reducing morbidity and the prevalence and intensity of schistosome infection. However, there are still several challenges hindering control and elimination. The challenges are a number of them, but I'll tease out a few for this presentation. For example, one is poor MDA coverage. Poor MDA coverage is as a result of inadequate health education and sensitization that is before MDA, because sensitizing people is not something that can be done in a month, in 2 weeks. So it is something that should be gradual, to sensitize people about these programs. Then inadequate supervision of VHTs by health workers, inadequate praziquantel to treat all at-risk age groups. So far, the praziquantel that we receive as Ministry of Health is donated by WHO, and it strictly is for treating school-age children. So meaning adults are not catered for, and yet research shows that we have adults who are also suffering from schistosomiasis. Another challenge that causes poor MDA coverage is fear of side effects. We always experience a lot of challenges during MDA, like vomiting, some school-age children who have taken the medicines do faint. There are a number of side effects that always happen. So the population, they fear such side effects and end up not taking these medicines. Then another challenge is lack of pediatric praziquantel to treat preschool age children. I will highlight a few. Pediatric praziquantel formulation is on the way, and we hope by 2024 we shall be piloting it, and Uganda is among the few countries that are going to benefit from the pilot implementation. So once it comes, we believe that this targeted population of preschool age children, once they are treated, we shall also minimize on the prevalence and the children who are suffering from schistosomiasis. Then we have difficulty integrating STH and schisto-MDS. As Uganda, we do implement mass drug administration for schisto at the same time with the albendazole or mebendazole for STH. However, as a program, we always find it sometimes hard to integrate the two programs. Then we have inadequate morbidity management of schistosomiasis cases in health facilities. Our health facilities are not well equipped. They are not trained to manage schistosomiasis morbidity. So it is also another challenge that is still hindering the control and the remission of schistosomiasis. Then we have inadequate external funding to support activity implementation. As I talk now as a program, we've been having the SIF, that is ARISE, supporting MDA in 75 districts. However, the funding ended in last August 2022. So as a program, we are still wondering where are we going to get funding to support these previously ARISE supported districts. So it is also another challenge that sometimes we are not consistent in the treatment, which has hindered the elimination of schisto. So with the introduction of pediatric praziquantel, are we going to benefit as far as mass drug administration is concerned as a program? Yes. We believe that treating preschool age children will help us to reduce the general burden of schisto in endemic areas. It is also likely to help us reduce morbidity in later life. It will also increase MDA coverage, as now we are bringing in mothers, caretakers of these young children as they come for treatment for these children. We do a lot of sensitization, we do a lot of mobilization. So we believe that once we enroll the pediatric praziquantel implementation, it will help us as far as MDA implementation is concerned. Then reduce knowledge gap about schistosomiasis and STH among different categories of people, including health workers, politicians, parents, caregivers. A number of stakeholders will be brought on board since we are developing a pediatric praziquantel sensitization and mobilization toolkit strategy that will be implemented, and this will help us to do a lot of awareness and mobilization. Then introduction of pediatric praziquantel will also help us increase the collaboration and coordination between the program and other child-related programs such as nutrition and immunization programs. These are people we are working with in this pediatric praziquantel formulation, identifying delivery platforms, doing formative research. We are working closely with other different organizations, for example, even academias, Makerere University. So we believe that this opportunity of pediatric praziquantel formulation is really going to help us in improving our MDA coverage. And at the same time, the programs mobilizing for the program Then more awareness will be created on schistosomiasis during the rollout of pediatric praziquantel. How is this going to be done? We are going to have opportunities for health facilities to advocate for PZQ supply and be able to diagnose schisto. As we talk now, if we want to diagnose schisto, we must take the technicians from the central team. So, but when pediatric formulation is going to be implemented, we are going to begin doing test and treat, which will build the capacities of health facilities and different of health facilities to be able to diagnose and treat for schisto. It is also going to help us integrate health education programs on MDA. It will increase stakeholder engagement. As I've already said, that we are going to bring a number of stakeholders on board. We believe that this is going to be an opportunity for the program and the division at large to be able to increase stakeholder engagement as far as mass drug administration is concerned. And then it is going to increase knowledge and awareness about schisto. Some people, when you ask them, do you know about schisto? They will tell you they are educated and learned, but they don't know what schisto is all about. So this is an opportunity. These ones I talk of policy makers, because as we do policy documents, we shall engage them. We believe that this is something that is going to really increase on the knowledge awareness about schistosomiasis. Then another benefit, I believe that introduction of pediatric praziquantel is going to bring to us is the overall reduction in disease burden. And at the end of the day, it will also help us in elimination of schisto, since this is the targeted, this is a group of people that have not been getting medication, and yet research shows that these people are also affected with schistosomiasis. Ladies and gentlemen, I want to thank you for listening in, and my acknowledgement to Ministry of Health, local government. These are people we implement mass drug administration with. SCI, we are grateful for the support you've provided to the program since 2013 to date, and other partners that have really supported us, and they are still supporting us to ensure that we control and eliminate schisto.
Thank you very much, Prudence, for sharing the perspective from the country, from an endemic country, which will start or has already started with the preparations for the introduction of pediatric praziquantel. As a next speaker, we have Steffi Knopp. She is unfortunately not able to be among us here. It's also a recorded presentation. She's a colleague of mine at Swiss TPH, an epidemiologist, and her main area of research is the diagnosis, epidemiology, and control of helminth infections in sub-Saharan Africa. Can we have, please, the recording?
Yeah, hello everyone, and thank you very much, Peter, for organizing this very important session, and also for giving me the opportunity to present on key developments in schistosomiasis control and diagnosis beyond pediatric praziquantel. I would say one of the big developments over the past years, and actually this year, was the publication of the new WHO guideline on the control and elimination of human schistosomiasis that does have as a goal to provide evidence-based recommendations to countries in their efforts to accomplish schistosomiasis morbidity control and elimination as a public health problem, and to move towards interruption of transmission. And within these guidelines, the 5 phases leading to elimination of schistosomiasis are very nicely outlined from morbidity control towards verification of elimination. And in my talk here, I now present a table or figure that lead us through the morbidity control phases towards verification of elimination, and that also highlights the thresholds, interventions suggested, and diagnostics in place for all these phases. But I would also like to highlight a few gaps, research gaps, and also the research done in that regard, so that we get a complete picture of the needs that are still to be fulfilled. So if you now look at morbidity control, well, we see that in areas where we have a 10% prevalence or above, and where heavy intensity infections occur in more than 1% of the population, WHO now recommends annual preventive chemotherapy to everybody aged 2 years and above. And this is a big change, because before they recommended to treat school-aged children, and now it's the whole population almost. The WHO also suggests that health facilities are involved in testing and treatment of all ages, even below 2 years. And they also say that wash and water engineering and snail control and behavior change interventions are, of course, an asset to mass drug administration or preventive chemotherapy. The diagnostics that we do have in place for areas where morbidity control is indicated are the cut-to-cuts and urine filtration microscopy, and also the point-of-care CCA test. If we now move to the next stage, this will be areas with a below 10% prevalence. And in these areas, WHO suggests to either continue with annual preventive chemotherapy or to reduce the frequency or change to a test and treat approach. Elimination as a public health problem is achieved in areas where we have below 1% heavy intensity infections in the population. And here the mention is that there is really a lack of a reliable test that has hindered the development of maintenance strategies so that elimination as a public health problem can be maintained. And that's an important point. The next stage is interruption of transmission that has been achieved at 0 prevalence, and where, for post-elimination surveillance, it is indicated to test humans, snails, and non-human mammalians. And here WHO points out that continued action is required to prevent the re-establishment of transmission. In terms of diagnostic, they suggest a 2-step approach with a highly sensitive point-of-care diagnostic test that then, and subsequently with a highly specific test that is to confirm the cases that have been identified with the sensitive test. And this highly specific test could be implemented in a laboratory rather than a point-of-care setting. So this is all very helpful, but as I said before, there are some question marks. And the first one, for example, is with regard to annual preventive chemotherapy, including everybody above the age of 2 years. Is this really possible? As I said, this will be like a much higher amount of praziquantel needed than when only school-aged children should have been treated. Much more resources in terms of praziquantel and implementation costs. So we need to find a strategy on how we can do this, so program managers can do this. And the good thing about schistosomiasis is that it is a very focal disease. And since it is a focal disease, not all areas might need treatment, but only those above 10%. And to identify those areas, we need precision mapping to then target preventive chemotherapy. Precision mapping, to my knowledge, was first mentioned or highlighted in an article in 2018 and taken up by the Global Schistosomiasis Alliance and the NTD Modeling Consortium in a meeting where precision mapping for schistosomiasis elimination was discussed. The Modeling Consortium continued with meetings and preparations for precision mapping. And also in last year core NTD, there was a breakout session on putting schistosomiasis precision mapping into practice. And 2022 are the first year where first results on the practical implementation of fine-scale mapping or sampling designs for schistosomiasis controls in regard to precision mapping are published or presented on recent conferences. So there is progress, and these experiences and calculations will hopefully lead into new guidelines on how to conduct precision mapping. The second question that occurs is, for example, with regard to test and treat, which is a great suggestion, since only those that are positive should receive treatment, but how can test and treat be done, and what diagnostics can be used for it? An example where test and treat is tried as surveillance response is Pemba Island, and this is done in my research group. And Pemba Island belongs to the United Republic of Tanzania and has achieved elimination as a public health problem already in 2017. Pemba has a lot of areas where prevalences are extremely low and also intensities are very low. And here we conduct the surveillance response approach, in that we start with active surveillance in schools, where we screen all school children at risk. The positives are treated with praziquantel and tracked to their homes, where we offer testing and treatment to their household members. They are also tracked to the water bodies that they are using, where test and treat excuse me, is offered to people using these water bodies. And where also the snail team goes and conducts mollusciciding if the intermediate host snail is present. In addition, we have health facilities that conduct passive surveillance to those presenting with schistosomiasis symptoms in the health facilities. And what we find with these approaches is that in cross-sectional surveys, we do have an extremely low prevalence here at the baseline survey and also the first-year follow-up survey of below 1%, and this is in a randomized population. But if we conduct targeted surveillance, reactively go to households or to water bodies, we find those that are infected, a much higher percentage of people being positive than in the randomized cross-sectional surveys. So our approach with tracking positive children really leads us to those in need of testing and treatment, which is great. And a similar approach and also similar results are published from Egypt and from Tanzania in the American Journal of Tropical Medicine and Hygiene. The next question pertains to the new diagnostic tests that are needed for maintaining elimination as a public health problem or post-elimination surveillance, for example. And in terms of diagnostics, we do know the cuts and urine filtration methods and the POC-CCA that are great once the infection intensities are high and X can be identified in a sample. But they lose sensitivity when infection intensity decreases, so for example in elimination settings. And therefore we urgently do need new diagnostic tests. And these new diagnostic tests should fit the reassured criteria, which means that they should present results in real time, that they should use specimens that are easy to collect, for example urine samples, that they should be affordable, sensitive, specific, user-friendly, rapid and robust, ideally equipment-free, and accessible to the end users. And in that regard, WHO has also published in 2021 new target product profiles for schistosomiasis diagnostic tests. One TPP pertains to monitoring and evaluation, and a test that reliably measures 10% prevalence thresholds, and the other TPP is for transmission interruption in subsequent surveillance, where the test should reliably detect a 3% prevalence threshold and is highly sensitive and or specific, potentially only in a two-stage approach. In terms of diagnostic test development, we know they are the point of care CCA test, and there's also a point of care CAA test in the pipeline that is not yet commercialized, but hopefully will be available soon. We have the molecular assays, the standard qPCR, and the lump RPA and peak PCR that might be more applicable at the point of care. And we have antibody assays, for example, here the point of care immunochromatographic test. The issue with all these tests, also according to WHO, is that their sensitivity is either not better than that for the basic tests, or that they have challenging laboratory and technical requirements, or challenges with feasibility and implementation in resource-poor settings, or that they are not standardized, quality controlled, or commercially available. So in summary, we can say it's great that we have new guidelines for control and elimination and diagnostic TPPs, but there is definitely a need for more evidence and further development of, for example, the practicability and cost effectiveness of precision mapping and targeted preventive chemotherapy, for new tools and strategies to maintain elimination as a public health problem, for tools and strategies to proceed towards interruption of transmission, and that entails diagnostics that meet the reassured criteria. Thank you very much for your attention.
Very good. This has taken us a bit beyond the pediatric praziquantel work and opened the field to, in general, schistosomiasis. And with the last speaker, we will now even leave schistosomiasis and look a little bit beyond. Katie Oldenburg is an infectious disease epidemiologist with the Proctor Foundation at the University of California. And her research interests focus on antibiotic-based interventions for child mortality, trachoma, and malnutrition. Katie, please.
Thank you, Peter. I'm just going to go ahead and share my screen. Oh, I'm not allowed to share my screen. Let's see. Oh, there we go. Okay. Thank you so much, Peter, and thank you for inviting me to this presentation. So I am going to switch topics a little bit that's relevant in terms of pediatric targeting of antimicrobials, but talk about trachoma. So in this talk, I'm going to go over some of the evidence we have for targeting pediatric populations for trachoma control with azithromycin. As many of you know, trachoma is very much a poverty-related infectious disease, another one of the neglected tropical diseases that causes blindness. The World Health Organization recommends annual mass drug administration to all individuals aged 6 months and over with a single oral dose of azithromycin. This is delivered as an oral suspension for children or tablets for people of over 7 years of age. And so the figure, this picture on the right here is of a trachoma MDA program in Ethiopia. We know that, so the ocular chlamydia, which is the causative organism of trachoma and is the target for azithromycin, the prevalence is highest in young children. So we see a highest prevalence in children about age 1 to 5, and then it starts to decline. It remains relatively high through the primary school age children, but declines as children get older. And then it's quite low, even in the highest transmission settings in Ethiopia, in older children and in adults. So this has led to some hypotheses that perhaps targeted treatment strategies specifically to the children could augment mass drug administration in areas where we've seen persistent trachoma. So we have some districts in the world, particularly in Ethiopia, that have received 15 or 20 years of annual mass drug administration and still have quite a lot of trachoma. So perhaps targeting these children in addition to mass drug administration could help bring that infection prevalence down. Or could reduce antibiotic consumption if effective alone. So if we could only target a core group of children, either based on all children or some other indication, perhaps it would reduce antibiotic consumption at the community level. So a few different strategies for targeted treatment have been evaluated, and I'll talk about some of these. The first two, I think one feature here is that these targeted strategies all involve more frequent dosing of children. So either quarterly or biannually for children based on their age. And other strategies have looked at targeting children either with infection, so looking for chlamydia itself by collecting a swab in the field and processing it in the lab with PCR, or targeting children or their households that have TF based on a field exam. So going out into the field, measuring, looking at the conjunctiva and measuring inflammation due to trachoma, either the clinical sign TF, trachomatous inflammation follicular, or the more severe inflammation TI. So these data here are from a community randomized trial that happened in Ethiopia. And this was a study that looked at targeting children aged 1 to 10 years with quarterly treatment, so 4 times a year dosing, compared to an annual mass drug administration. And so the figure on the right here on the top panel shows the prevalence of infection in children with time on the x-axis in months going forward from baseline. So these were communities with between 40 and 50% prevalence of infection at baseline, so quite a lot of infection. The line in green is the prevalence at each time point in the children only treated group, so targeting only those 1 to 10-year-old children. And in purple is the mass treatment group, so the communities in which everyone received a single mass drug administration for trachoma. And then there's a blue dot at the end at 12 months. This was a control group which received no antibiotics and did not receive interim monitoring. So they only measured at the 12-month time point. And what we can see in the children is that in both arms, so again on this top panel, both arms, the prevalence of infection reduces quite quickly after that initial treatment and stays quite low in both groups, and that the prevalence of infection is lower in the children only targeted group compared to the mass drug administration group. An additional question is that just because they have lower prevalence of infection doesn't mean that they have no infection. So the bottom panel there is looking at older children, those who are over 11 years of age, and the adults to see if we have a reduction of infection, sort of an indirect effect. So does treating the younger children affect prevalence in the older children and adults? And we can see here at the 12-month time point that there's no significant difference between treating the children only compared to the mass treatment group, suggesting that there is some evidence of an indirect effect. So treating just those core group of children is reducing transmission, which then has positive benefits to others in the community. We've also looked at twice annual treatment, so quarterly treatment requires quite a lot of effort to get out into the community. So looking only at twice yearly treatments compared to, here it's compared again to annual mass drug administration. So this is data from a community randomized trial in Niger. You can see here that the prevalence of infection at baseline was lower. So these are in communities with about 20% prevalence of infection at baseline. The top panel here is annual treatment, which is MDA to all individuals over 6 months of age. The bottom panel is biannual treatment to children aged 1 to 5 years, or 6 months to 5 years, excuse me. So twice yearly treatment, and they were followed for 36 months. And in both communities, we see rapid and sustained reduction in ocular chlamydia, in the prevalence of ocular chlamydia infection. And there's no evidence of a difference between the two study arms. So then finally, thinking about targeted treatment, which here refers to identifying groups of children, subgroups of children based on a criteria other than just their age. So the hypothesis being if we can test people for infection or if we can identify active trachoma in the field, which is easier than testing for infection, can we treat only those children? And is that enough to reduce transmission at the community level, given that we know that treating all of the children can actually reduce community transmission? These are data from a trial in Ethiopia that had about 10% prevalence of infection at baseline. In this particular study, they identified children aged 1 to 5 years or 0 to 5 years who had infection. And they treated them 3 times annually over a 2-year basis. And so this study is looking, these data are showing on the left, the prevalence of infection over that 24-month period in the 0 to 5-year-olds. So this was the treated group. And then 8 to 12-year-olds, ones who were not in the targeted, in that core group on the right. The green bar here is the prevalence of ocular chlamydia infection in the communities that got mass drug administration. Orange is the targeted under 5-year-old treatments. And the blue line is a delayed group, which did not receive any antibiotics until the end of the study, until after that final monitoring visit at 24 months. And overall, we see worse performance of kind of the targeted strategy just to the children who have infection. So a much smaller group of children, about 10% of them will be treated under this strategy because it's only treating the ones with infection. And so for the 0 to 5-year-olds, we see that the prevalence of infection is just as high at the 12-month visit as it is in the delayed arm. It does decline up to 24 months. But we don't see any evidence that in the older children with this strategy that we're reducing ocular chlamydia infection like we did when we treated the entire younger child population instead of just a subset of it. So we see some reductions, but it's not as good as treating all of the children based on age. So a benefit of this, of course, is that it reduces the amount of antibiotic distributed, which in theory should reduce the amount of antibiotic resistance that we're selecting for, but it does not appear to perform as well as mass drug administration or targeting all of those children based on age. So in summary, targeting azithromycin to pediatric populations does appear to be as good as annual mass drug administration for reducing ocular chlamydia infection. So it's a potential strategy in many different epidemic settings for treating azithromycin or treating trachoma. We can reach very large numbers of children and treat them based on a variety of criteria. So we can target them based on their age, based on the presence of clinical disease, or based on infection. Although the evidence suggests that a more narrowly defined core group targeting strategies don't perform as well as those that are based on broader criteria. We do have future work ongoing now. We have a trial going on in Ethiopia now that's looking at targeted strategy, so an intensive treatment strategy in conjunction with mass drug administration. So a strategy in which everyone in the community receives annual mass drug administration, and then children, based on either their age or clinical disease, are treated 3 additional times during the year to evaluate whether that will further reduce trachoma in persistently high transmission settings. I'd like to thank my colleagues and collaborators on these projects, and thank you very much for your attention.
Thank you very much, Katie. This was a very good insight from another program targeting the small children we are talking about here for the pediatric praziquantel considerations. In the interest of time, we suggest to go straight into the breakout groups. I have seen there was already quite some activity to answer questions in the chat, and I hope the most pressing points have been clarified. We have 2 breakout rooms. One focuses on mass drug administration, discussions around MDA in small children, and the other one on test and treat as an alternative. And I think we have all received very rich input from the presentations, and I'm looking forward to then hearing very short, succinct summaries of the discussions in the 2 rooms. Can we please have the breakout rooms? Everybody is free to choose where he or she would like to join, so we don't assign automatically people to this or that breakout room. We come back to the main room. We still give 1 minute for others to join. It seems not everybody found his or her way back to the main platform here. So, welcome everybody. I think we are back. Almost everybody found his or her way here. I have switched a bit between rooms. It seems we had good discussions in both of them, and of course, not enough time, as always, in this type of meetings. But still, we would like to hear what we could gather as information, as key points to remember to take away from these discussions. And first, I would like to invite Ashley Preston from Breakout Room 1 to summarize the key points that were mentioned.
Thanks, Peter. So we had some good discussions around the possibilities and opportunities for integration in relation to different mass delivery platforms. And some of the key points that were made were around really identifying which programs are already targeting these preschool age children, thinking about, for example, immunization programs or polio, and then how to sort of leverage that. And some of the key areas around raising interest in those groups are looking at thinking about advocacy in those high-level multi-sectoral meetings, and using those for planning and also for raising awareness and for creating demand and interest. And then also thinking about how to understand the need in the preschool age children. There was a suggestion around mapping in that group to really support the introduction. And then thinking about what might need to be considered in terms of the challenges of integration. For example, the time frame of administration and whether that sort of co-planning can work in developing the different work plans that would be required for that. Thinking about as well, in terms of the integration, do the programs have the same coverage and consideration of the indicators? Thinking about the data reporting tools and how that can be harmonized. Also thinking about how to coordinate between those key different platforms. For example, if you have two departments, who actually should take charge, where does the funding sit, who's going to sort of facilitate that coordination. And a good suggestion was learning from opportunities from other programs where integration has already taken place. Also thinking about what are the opportunities for integration. There was a good discussion around thinking about the health system structure and really those key building blocks, for example, the leadership and governance, and how the delivery structures, the personnel available, and the health information systems and the drug logistics systems, and really considering each of those aspects when trying to align and consider integration. I think they were all the key points, but if anyone from the group wanted to add anything that I've missed, please feel free.
If this is not the case, I know it's always difficult to choose which breakout room to join. We would have 2 minutes to allow comments or questions from those who did not join this breakout room. Just raise your hand or write in the chat. If this is not the case at that moment, then I thank you very much, Ashley, for this excellent summary of the discussion. And we would invite now Yael Welleman to summarize from breakout room 2.
Thanks, Peter. We also had great discussion about the implications of switching to testing and treating. So the first question was around the for and against arguments around test and treat beyond the WHO guidelines. A few key things came out of that. The first one was, do we actually have the right tools for testing and diagnostics at the moment? Some felt that we really do need to have the right kind of diagnostic method before we move to test and treat. But there were also other options brought up. for example, around the use of antibodies before we get point of care testing that's more accurate, although there was also a strong feeling that that's forthcoming and shouldn't really hold us up for now. But there were also some discussions around the fact that just as important is knowing where and who to test. And our attention was drawn back to the session yesterday around micro or precision mapping, so that we know better where infection is happening, where the prevalence and severity of infection are highest, in order to inform where we need to apply, test and treat. And there was some discussion around the fact that some countries, such as Ethiopia, for example, already do have the right sort of data around where treatment should happen in a more targeted way, but they're still determining or not quite sure how that needs to work with the health system. So again, do we have the right tools? What do we do in the interim? And also just knowing that we need to have the right kind of data to provide the ministries of health with the ability to decide where to apply, test and treat. Then we talked a little bit about delivery platforms, so not the diagnostic approach, but the actual process for how test and treat could be delivered. So there was a bit of a back and forth around whether it's about integrating into routine healthcare provision, whether it's about people being able to turn up at healthcare facilities and be tested and treated. There are some issues with that, especially since schisto is a bit of a silent disease. So do people know to turn up and ask for these tests? Or do we need to actually integrate into routine programs similar to the EPI, the expanded program on immunization, where you do have these kind of routine clinics where you'll be testing and treating as well alongside immunization or other programs, or even using malaria programs, for example, where you're already using finger prick technology to test people for malaria. Or whether we should be using a campaign approach where, again, similar to maybe polio immunization, where we're just actually doing outreach and testing and treating people there. So a lot of discussion, and then there was also a point around a bit of the chicken and egg issue. So the more that we talk about test and treat and implement it, the more this would encourage a market response to developing better point of care technologies for testing. And keeping in mind that we also need to make sure that there are clinical protocols in place. So when a positive test is identified, healthcare providers know what to do and which treatment to apply. We didn't get to all of the other questions, but there was definitely one very clear operational research question around really identifying those best platforms for delivery of testing and treating that respond to the context in different countries. I hope that's a good summary. Open to comments.
Wonderful. Yes, comments, or as with the last one, additions from or questions from those who could not join. Yes, we have one hand raised. Akinola.
Thank you very much, Yael, for that summary. And I could see the discussion going. I think what I just wanted to add, or maybe what they must have think about, is about, depending on which approach they want to use, we also need to consider the capacity building of the health workers. If they intend to integrate it into the healthcare system, how do we, then there will be need for capacity building of those health workers to be able to do those diagnostic tests, bearing in mind that not all health facility could have a laboratory section. So the health workers, frontline workers in those communities who are closest to the endemic community, we need to have their capacity built if we're trying to integrate it into the health system, into the primary health care setting. So those are some of other things that may need to be considered even around, test and treat.
Thank you very much. Anybody else want to raise hand? I don't see in the chat, except that we are almost running out of time. Any last minute addition, question, clarification? No, then I would like to say thank you very, very much to all who listened, all those who contributed with questions and comments, and of course the speakers and breakout room chairs, the three rapporteurs, all have invested a lot of time. I think it was a very interesting and rich session, and as a general conclusion, I think it's fair to say around this topic of treating pediatric patients against schistosomiasis, we will have enough research to go on for several core NTD meetings to come, and also for a lot of activity in the field. That's where the patients are and where the activity ultimately needs to happen. A big thank you again to all of you, and wishing you a very interesting continuation of core NTD. Thank you.